So good evening everyone, I am Dr. Naveen Porwal, your physiology educator on Unacademy. And if you want, you can subscribe to Plus subscription of Unacademy. There you will get daily live classes. Okay, and there will be a lot of structured course, there will be a lot of batch courses, live test and quizzes, and you have unlimited access to almost every course, every educator. Okay, and if you use the code physio10, you will get 10% discount on an Academy Plus subscription. And if you opt for Iconic subscription, you can get an Academy. Along with that, you can get prep ladder, which are recorded session. And this is how, what are the features, key features, how it look like. And coming to today's class, today we will be discussing clinical MCQ of kidney, renal. Okay, so on YouTube this will be last session today. Next session I will take in next month. Okay, yes, good evening Moksh, good evening Rizwan, Mahmood. And from tomorrow, those who are in Unacademy, from tomorrow I am going to start a clinical MCQ discussion, and it will start from 5:15 to 7:15 p.m. every day. It is an intensive revision of physiology clinical MCQ from tomorrow. I mean from 24th, then 25th, 26th, 27th, 27 and 28. From 24 to 28 every day 5:15 p.m. to 7:15. So those who are on Academy can join me from tomorrow. Okay, coming to the question, a 9-year-old boy is brought to physician by his mother for evaluation of the general weakness. Increased urination, polyuria is there, increased thirst is there. The mother mentioned that her body is always tired and seemed to getting worse. He prefer watching television rather than going out. Furthermore, he has frequent episode of constipation since birth. Okay, except for frequent craving for salty food, patient might be having hyponatremia. The boy eat a regular diet. The patient was delivered healthy. So maternal history is almost normal and fully immunized. Medical history is unremarkable, and he takes no medication. No sibling is there. Pulse is 90 per minute. BP is a little bit less, and respiratory rate is 15 per minute. It's 15 per minute. He is in the bottom 10th percentile of the height and weight according to the age. So you can see that height and weight both are less. Okay, and this is the lab workup. Hyponatremia is there, hypokalemia you can see is there, renin is a bit high, there is increased renin, and also increased aldosterone level. There is also increased aldosterone. This is the lab parameter. Hyponatremia, kalemia, renin is high, as well as aldosterone is also, you can see 2 to 9 is the normal range, and it is 20 nanogram per deciliter. So which of the following is the most likely diagnosis? Renal artery stenosis, primary hyperaldosteronism, Bartter syndrome, pheochromocytoma, or Little-Man syndrome. What is your most probable diagnosis? You have seen hyponatremia, hypokalemia. Weight and height are below less than 10 percentile of the normal. Good evening Rizwan and Siddharth, Moksh, everyone. Good evening. What is your most probable diagnosis? Those who are on Unacademy, we can join from tomorrow 5:15 p.m. I will be discussing these clinical questions for 2 hours every day. Yes, tell me. Should I show you the question again? B is primary hyperaldosteronism. Please once again show the diagnosis. E is Little-Man syndrome. Okay, you can see this question again. This is the main part of the question. You can see it again. Serum electrolyte, hyponatremia, hypokalemia, renin is more, aldosterone is also more. So what is the answer? Dr. Nirmala, primary hyperaldosteronism. Okay. So most of you are opting for primary hyperaldosteronism. What happens in primary hyperaldosteronism? If aldosterone is more, it is also called as Cone syndrome. First of all, let me tell you this is not the answer. Answer is not. Answer is C. Bartter syndrome. Let me explain you why answer is Bartter, not Cone syndrome. What happens in Cone syndrome? There is increased aldosterone. And if there is increased aldosterone, my dear friend, tell me first, there will be increased sodium reabsorption or not? There will be hypertension or hypotension? What do you think? There will be hypertension or there will be hypotension? Sodium will be more in the blood or less in the blood? Of course, potassium will be less. But you can see in this case, BP is 110 by 75. Blood pressure is 110 by 75. So if it would have been Cone syndrome or primary hyperaldosteronism, due to primary increase in the aldosterone, sodium will be more, not less, and hypertension, not hypotension. Okay. So what else is left? Bartter and Gitelman. It is not pheochromocytoma. There is no hypertension. So these are ruled out. Remaining are Bartter and Gitelman. You might be knowing about the Bartter and Gitelman syndrome. The answer is Bartter. Why? Because in Bartter what happened? If you remember about TAL, thick ascending loop of Henle. If you remember about your thick ascending loop of Henle, on the basolateral membrane there is sodium potassium pump. Then there is a channel called as sodium potassium 2 chloride channel. Then for potassium it goes back by ROMK, renal outer medullary potassium pump. By this it is secreted back, and chloride is taken by two protein. One is called as Bartin, other is called as CLCKB oblique CLCK. Also, sir, Bartter is diagnosed early in life. Of course, Bartter is diagnosed early in life. Okay. So you might be remembering about Bartter syndrome. If you remember, I hope you remember, there are 4 types of Bartter syndrome. I hope you remember this. There are 4 types of Bartter syndrome. If there is mutation of NKCC, it is called as type 1 Bartter syndrome. If there is mutation of ROMK, it is type 2 Bartter syndrome. So many times I have told you. If there is mutation of CLCKB, it is called as type 3 Bartter syndrome. If there is mutation of Bartin, it is called as type 4 Bartter syndrome. And type 4 is also associated with sensorineural deafness, because Bartin gene is also in the internal ear, involved in the hearing, and this is called as classical Bartter syndrome. This is called as classical Bartter syndrome. And if there is mutation of these pump, sodium washout will occur. Sodium washout will occur. So there will be sodium washout. So polyuria and hyponatremia, isn't it? Polyuria and hyponatremia. But you can see polyuria and hyponatremia. But when there is more sodium, coming in the lumen, more aldosterone will be released. It is called as secondary hyperaldosteronism, so that sodium can be reabsorbed and potassium can be secreted. So that will cause secondary hyperaldosteronism as well as hypokalemia, and this will also cause metabolic alkalosis. So this is behaving like a diuretic, loop diuretic or furosemide. So answer is Bartter syndrome. Because in Liddle syndrome, what happened in Liddle syndrome? Anyone can tell me? Sorry, Gentleman syndrome, not Riddle. What happened in Gentleman syndrome? In Gentleman syndrome, okay, let me explain this also. In Gentleman syndrome, on distal convoluted tubule, there is mutation of an sodium chloride channel, and this behave like diuretic thiazide. Okay, and one thing which is very interesting here is that you will also get hypomagnesemia along with the hypokalemia, metabolic alkalosis. You will also get hypomagnesemia. Okay, so answer is Bartter syndrome, not Gentleman syndrome, neither primary hyperaldosteronism. Now coming to the next question. This is so next question is that, okay, researcher developed a drug X that act on the loop of Henle, but discovered that it does not reach its intended site of action. So it is freely filtered but rapidly disappear from the proximal tubule. Remember, it is freely filtered but rapidly disappear from the proximal tubule. This is about the drug X. Now they have modified property of X, so this become drug Y. So drug Y cannot be reabsorbed from the proximal tubule. Drug X cannot reach beyond proximal tubule. It disappears. It is fully absorbed from proximal tubule, and drug Y cannot be reabsorbed from proximal tubule. Neither drug is secreted into the proximal tubule. So which of the following natural substance are most similar to the concentration profile of drug X and drug Y in the proximal tubule? So drug X is acting like what? Glucose, creatinine or amino acid. So there are the option: creatinine or glucose, glucose or creatinine, glucose potassium, potassium creatinine, creatinine potassium. What is your answer? So if you want to see question again, drug X cannot go beyond proximal tubule because it rapidly disappears. It means it is fully absorbed from proximal tubule, and drug Y is neither reabsorbed nor secreted. Yes, Moksh, your answer is B. B means glucose and creatinine. Yes, very good. So you can see here that it is behaving like glucose because glucose is reabsorbed 100% from proximal convoluted tubule, and creatinine inside the body itself, it is fully filtered. If you remember, it is fully filtered but neither reabsorbed nor secreted. Neither reabsorbed nor secreted. So answer is glucose and creatinine. Very good, excellent. Now question number, so I want to discuss this diagram is very important for your exam. See, this is tubular fluid by plasma ratio. If it is more than 1, it will be on the upside. If it is less than 1, it will be on the downside. If it is less than 1, it means what? It is fully absorbed, maximally absorbed, like glucose and amino acid and 80% of phosphate and bicarbonate. Okay, and if it is not reabsorbed, like para-aminohippuric acid, like creatinine and inulin, like urea, this will be above this. So this graph can come in your examination as an image-based question. Remember that if it is absorbed more than secreted, it will be on the below side. Like glucose is fully absorbed, amino acid is fully absorbed, pH means phosphate and bicarbonate is absorbed 80%. Okay, so those are absorbed in the proximal tubule will be on the downside because on the tubular fluid it will be less than plasma. And those which are on the upside, it means they are not reabsorbed. That is why they are more on the tubular fluid, like para-aminohippuric acid. It is used to calculate your renal plasma flow. It is used to calculate renal plasma flow. Creatinine, it is used to calculate GFR. Inulin and creatinine is for GFR. Okay. Please remember this diagram. Coming to the third question, listen very carefully. A 47-year-old woman present to physician for evaluation of vomiting and diarrhea for 2 days. Her symptoms began following a company picnic. Okay, all these things are there. Mild headache, relieved by acetaminophen, paracetamol. BP is absolutely normal. Heart rate is, on the low side. On examination, mucous membrane are dry and eyes are slightly sunken. Where is the most of the sodium reabsorbed in the patient kidney? Question is only this much. That is the description. But the main question is that in which part of the nephron maximum sodium is reabsorbed? One liner question. From which part of the nephron maximum sodium is reabsorbed? Collecting duct, distal tubule, descending loop of Henle, proximal tubule, or ascending limb of loop of Henle. What is the most correct answer? Question is that patient is having dehydration. Which part of the nephron? So everyone should know always that almost everything is maximally absorbed in proximal convoluted tubule. For example, 100% reabsorption of glucose and amino acid occur in proximal tubule. 80% reabsorption of pH, phosphate, and H means bicarbonate. 70% reabsorption of calcium. 2 by 3rd, it means 67% reabsorption of sodium, it means maximum. Chloride, potassium, okay, a lot of things are there. Sodium, potassium, water, all these are absorbed 67%. So almost more than 66% sodium is reabsorbed from proximal tubule. So answer will be D. Good. So next question. A 35-year-old man is found to be in wilderness behind a sky resort where he was lost for 2 days, deprived of food and water. So for last 2 days he has not taken food neither water. He is rushed to the emergency department for medical care. Which of the following parameter will best describe his physiological state? So a man who has not taken food and water for 2 days. Okay, so what should be the best physiological state? What is the best answer? A, B, C, D or E? But I am not lost, I can take water. Yes, if someone is lost in a resort, so what should be the physiological parameter of this particular patient? Patient has not taken, yes, answer is water and food for last 2 days. Water deprived patient. Urine is decrease. Of course it will be decrease, not increase. This is wrong. Decrease. Okay. And osmolarity of the urine will be more. Of course it will be more. Increase. Not decrease. This is gone. Then free water clearance. You know free water clearance is what? If urine osmolarity is more, it is negative. If urine osmolarity is less, it is positive. And you know that in that case, water is not there. So free water clearance will be positive or negative. It will be negative. It will not be increased. Okay, it is not, it is decreased. This can be the answer and this can be the answer. Free water clearance can be decreased. Now ADH will be decreased or ADH will be increased. If there is no availability of the water, so there will be more ADH so that water can be reabsorbed. If you want to reabsorb water, there will be more ADH. So I think this will be the answer. Urine water will be decreased. If there is no, there is no availability of the water, urine water will be decreased, osmolarity will be increased. Of course, osmolarity will be increased. Urine will be, you can say urine will be concentrated. And when urine is concentrated, we say free water clearance is negative. It is negative. Do you remember this free water clearance? If urine is concentrated, free water clearance is negative. If urine is dilute, see there is blood osmolarity and then urine osmolarity. If both are equal, free water clearance is 0. If urine is dilute, free water clearance is positive. If urine is concentrated, free water clearance is negative. So here it will be negative, and because there is loss of water, so antidiuretic hormone will be increased. Okay, so answer will be E, isn't it? Okay, coming to the next question. Okay, these are, see, whenever you are getting a clinical question, first thing which you should do, read last line. Which substance can be used to most accurately assess the glomerular filtration rate in this patient? See, whenever, because time is less, and the clue to the clinical question lies on the last line. So first read last line option, and then if it is clear, it's okay. If not clear, then read every point. So which substance can be used to most accurately assess GFR in this patient? Now this is a simple one-liner question. Creatinine, insulin, urea, glucose, PAH. What can be used to assess GFR this patient? In any patient, it is same. In any patient is same. It is always, answer will be same. Yes, insulin is the best parameter. It is the best parameter, which is the surrogate marker of GFR. Which is the surrogate marker of measurement of GFR? Creatinine, but it is a bit more than GFR because it is slightly secreted. Okay, so it is around 140. So it is surrogate marker, not the best. Okay, and which PAH is used to measure what? It is used to measure, to estimate renal plasma flow. It is used to measure renal plasma flow. I am trying to collect this the exam which I have held in day before yesterday. When I will get every question, then I will take one YouTube session on that also. Okay, this is PAH, renal plasma flow. Okay, coming to the next question fast. Now this is a long question, let me explain that so that you should not waste your time. There are two medical resident volunteers, both are having almost same weight, 75 kg, approximately same weight, and resident A has normal lab profile. Resident A has normal lab profile. Resident B have normal lab profile. Resident B have normal lab profile. Now comes the question. Over the course of a single day, oral potassium is given to both volunteer. Okay, 25 milli equivalent to resident A and 250 milli equivalent to resident B. At the end of the day, the blood test shows both of the residents have equal blood potassium level. So what is the cause of that? There are two residents on which physiology department is conducting a test. Both are having no abnormality, lab profile is completely normal, weight is approximately same, but one is given 25 milliequivalent of potassium, other is given a lot of potassium from fruit juice or whatever, but at the end of the day, both are having almost same blood level of potassium. So what or which segment of the nephron is responsible for this result? And why? And why? Just tell me what is the answer and why. Very simple basic question. See, I want to just emphasize you that nowadays examination pattern is unpredictable. They can be one-liner, they can be clinical based. If your concepts are okay, don't fear. They can be match the following, Main thing is concept. Now you are not going to get repeated MCQ. They are trying to check your concept. So try to focus on only concept, not on the previous year paper. Of course, you have to solve all MCQ from your NEET PG, AIMS, PGI, US Assembly plan. This will help you. But you have to build up your own concept. Yes, D, A, because hyperkalemia stimulate. Yes, whenever there is hyperkalemia, this is the most potent stimulator of aldosterone. This is the most potent stimulator of, yes, Akshay Gupta and Moksh, of course, and this will act on collecting duct, so that aldosterone can come here. Secondary hyperaldosteronism, which will reabsorb sodium and remove the excess potassium. So at the end of the day, there will not be hyperkalemia. Otherwise, do you know what happened to hyperkalemia? Who can tell me what happened in hyperkalemia? Patient can die, heart can stop because of a process called as accommodation. If you remember the basic physiology of hyperkalemia, I will discuss that also. So this is cortical collecting duct where aldosterone is acting. Now please tell me what is going to happen in hyperkalemia. If there is prolonged hyperkalemia in any patient due to kidney failure, due to any cause, or hypokalemia, see, both are dangerous. Let me discuss this point, is very important. Let me add some page. Just a minute. Okay. Now tell me please, what is going to happen in hyperkalemia and hypokalemia? Who is going to tell me what happened in hyperkalemia? Now this question is really very, very important for your physiology as well as medicine. See, sodium is important, but it will not kill until it is very, very prolonged. Eh? But hypokalemia and hyperkalemia can kill, because you know life means what? What do you think of life? RMP means life. Resting membrane potential means life. It is present in every living cell. Without that, you cannot live. Okay, and RMP is formed by which ion? Which is the single ion. Yes, Akshay, RMP more positive, so reaching. Yes, very good, Akshay. Yes, so RMP is because of which ion? Sodium or potassium? Everyone knows that RMP is because of potassium. So when there is hyperkalemia, magnitude of RMP will be less or more? Tell me. Magnitude of RMP will be less or more in hyperkalemia? Who is going to tell me? Magnitude of RMP will be, yes, Akshay? Magnitude of RMP will be less, my dear friend. And hypokalemia, it will be more. Yes, I know that U wave, and I will discuss ECG finding also. I am not talking about ECG finding. Of course, that will indicate that patient is having hyper or hypo. But I am asking what is going to happen to the life. Yes, it will be less. It will be in hyperkalemia. RMP will be less. If you make the diagram like that, this is your RMP. This is your threshold. Suppose RMP is minus 90. Threshold is minus 70. In one condition, it will become A. In other condition, it will become B. What is A and what is B? What is A and what is B? Which is hyperkalemia, which is hypokalemia? Yes, this is suppose minus 80 and this is minus 100. Let me assume that. So what is A? A is actually hyperkalemia. In hyperkalemia, I told you RMP become less. So it will be closer. In hypokalemia, it will be far. So which is more dangerous, hypo or hyper? Both will be more dangerous. In that condition, it will be far from the threshold. So it is difficult to initiate. But in hyperkalemia, it is so close that it will keep on irritating. So what will happen? It will inactivate voltage gated sodium channel. So there will be no action potential. Here also there will be no action potential. But hyper is more dangerous. It is very close. It is very close. It is more dangerous. So in both condition, and this process is called as accommodation. What is accommodation? Accommodation means when repeated sub-threshold stimuli does not produce action potential. When you are giving repeated sub-threshold just below the threshold. Okay, do you know reason for that? Anyone can tell me the reason for that? Because voltage gated channels are having two. One is called as activation gate, other is called as inactivation gate. This is the resting condition, this is the depolarization condition. Both are on the downside. I am making so that you can understand. Okay, now this is the resting condition. Normally voltage gated sodium channels are resting condition. In that condition, this is when it is depolarized, and this is in the case of refractory period. So when you are giving stimulus to the resting condition, it will be depolarized, but after that it will become refractory. So until it come back to the resting condition, you cannot stimulate voltage gated sodium channel. So there is a need of some time. But when there is sub threshold stimulus again and again, okay, you are not giving time from refractory to resting condition. So it will be in the locked state. It will be in the refractory state. So hyperkalemia will not open voltage gated sodium channel, and your heart will stop. Your heart will, there will be cardiac arrest. Okay, and in hypokalemia it is so far that it cannot stimulate. Of course, in ECG, you were telling about the ECG. So in hyperkalemia, what are the ECG finding? What are the ECG finding during hyperkalemia? Just remember a mnemonic: PQRST. P wave will be absent, QRS will be wide, and T will be tented, tall tented T wave. Tall tented. So these are the three findings of hyperkalemia. Yes, P wave will be absent, QRS will be wide, and T will be tall. And in hypokalemia, what happened in hypokalemia? I have given you a mnemonic, if you remember. Yes, Moksha, remember the mnemonic? Stupor. ST wave depression, PR will become less, and U wave. Plus T wave become inverted. So remember stupor, ST wave, U wave, and PR wave. Changes will be in ST wave, U wave will be there in hypokalemia, and PR. Okay. Yes, very good, Akshay. ST changes, U wave and T wave inverted. PR will also be infected. Yes, QRS will be broad. QRS is broad in the hyperkalemia. QRS wide will be in hyperkalemia. Okay. So I hope this much is clear. Okay, so thanks a lot for joining the session. From tomorrow, those who are on Unacademy, from 5:15 p.m. okay, to 7:15, I am going to discuss all the clinical MCQ of all the subject. I mean all the system of physiology. I will start with renal, then respiratory, then cardio and all. So clinical MCQ will be discussed. So those who are there can join me, and those who want to join, Unacademy, subscribe Unacademy, you can subscribe, and if you put the code physio10, you will get 10% discount in that. Okay, and I will also planning to take special class along with that. I will tell you that. Thanks a lot, everyone. Thanks Moksh, thanks Nirmala, thanks Ananya, Akshay, Naveen, Nazir. So everyone, thanks a lot. Thanks. Your name is very difficult to pronounce. I don't know. Kailino. Okay. Thank you, everyone. So for more session like that, you can join me. You can just follow me there on Unacademy. And if you like this video, please like this. Share with your colleague. Thank you. Thanks, everyone.